Dr. Elizabeth Joseph, Madam. She is the HOD of Little Flower, Angamali, and she was the first doctor in Kerala to start pediatric ophthalmology department in LF.
Good morning, everyone. I will be presenting about the role of imaging and the challenges we face in the management of third nerve palsy. So you all know that third nerve nucleus is situated in the midbrain. It has got various subnuclei. The Edinger-Westphal nucleus take care of the pupillary fibers and the ciliary ganglion, and that is the central caudal nucleus, that is a single midline nucleus that innervates both levator palpebrae, and the superior rectus nuclei supplies the contralateral superior rectus. Whereas medial rectus, inferior rectus and inferior oblique nuclei supply the ipsilateral eye. So in a nuclear paralysis, there will be bilateral ptosis and opposite eye superior rectus. With the same eye, medial rectus, inferior rectus and inferior oblique. That is how you localize whether it is a nuclear lesion or not. And coming from the nucleus, the fascicular portion goes through the medial longitudinal fasciculus, the red nucleus, substantia nigra, and then emerge from the midbrain in the interpedunculaire fossa. So as the third nerve passes through all these structures, there will be associated neurological findings like ataxia, hemiplegia, etc. in case of fascicular portion involvement. Then it travels through the cavernous sinus, superior orbital fissure, divides into superior and inferior divisions, and then innervates. So in all these places, the third nerve may be involved in different pathologies. The various imaging modalities, the primary imaging modality is of course MRI, because of its high soft tissue contrast and ability to show the entire course of the third nerve. MRI sequences used besides T1 and T2 weighted images is the diffusion weighted image. MR angiography is done if you are thinking about a vascular pathology. CT scanning has got limited role. This is important if you are suspecting an trauma, skull fracture and all. Digital subtraction angiography is reserved for cases in which cerebral aneurysm or carotid cavernous sinus fistula is suspected. See, now I will show you the picture of some of the images in the patients. See, this is a right posterior communicating artery aneurysm. You can see this is demonstrated in the MR angiogram, and then the T2 weighted image showing thickening of the aneurysm pressing on the third nerve. Then coming to another patient, a 57-year-old male presented with the left third nerve palsy and weakness of bilateral superior rectus. Bilateral incomplete ptosis. That was a nuclear lesion, and you can see a rim enhancing lesion, and that was a midbrain metastasis. Another patient, 53-year-old female, presented with incomplete third nerve palsy, contralateral ataxia. This is the ischemic infarct. So these are all neurological findings and will be managed by the neurologist. And this is a patient with a Toloso-Hunt syndrome, the painful ophthalmoplegic syndrome. Imaging shows thickening and involvement of the cavernous sinus and even the dura. Now coming to the clinical features of third nerve palsy, as we all know, patient presents with a ptosis. The eye will be fixed in the down and out position, and there will be exodeviation. Like in this patient, ptosis is there, eye is fixed in abduction, and there is defective depression and elevation. You have to think about that in third nerve palsy, as in any other cranial nerve palsies, the basic principle is that a good neurology workup imaging is a must, and wait for 3 to 6 months for recovery, and after that, if there is no natural recovery, then only do the surgery. A word about pupil sparing third nerve palsy. Isolated third nerve palsy with a normal pupillary function is more or less benign, and it's usually due to ischemia seen in conditions like diabetes and hypertension. In people sparing third nerve palsy, if there are no other neurological symptoms, you can give a good prognosis and can give conservative management. Most often that will recover. And those cases which is not recovering, then we have to think about the surgical management. And the surgical management of third nerve palsy is the most difficult for the strabismologists, because the results are not always very satisfactory, and the management depends on whether it is a complete palsy or incomplete palsy, and whether there is the presence of aberrant regeneration. See, look at this patient. He had this patient had an intracranial tumor presented with a total third nerve palsy with ptosis, and in such conditions, what will you do? When the eye is open, you can see the eye is fixed in abduction, and in such cases, look for some action of the medial rectus by forced generation test. If there is some action of the medial rectus, supramaximal recess resect surgeries will work. If there is no action of the medial rectus, we have to think about transposition procedures. There are superior oblique transposition to medial rectus, which is a very difficult procedure because it involves dissection at the trochlea. LR transposition to the medial rectus is now advocated with a fairly good result, but that again is a difficult procedure. Periosteal fixation to the lateral rectus, globe anchoring procedures, these are all done with more ease and a good prognosis. In isolated palsies, things are easier. If it is a superior oblique palsy, you can put the two horizontal muscle supports as in the NAP surgery, or you can weaken the elevators of the opposite eye. In inferior rectus palsy, you can have ipsilateral superior rectus weakening, contralateral inferior rectus weakening. MR palsy, if there is some residual action, recess resect. Inferior oblique palsy, if associated with superior oblique overaction, weaken the ipsilateral superior oblique and contralateral superior rectus. Now let us see some real conditions. This is a complete third nerve palsy with total ptosis. The patient was having an intracranial tumor which was operated, and we took care of the ptosis by doing the frontalis sling, and we did a large recession, supramaximal recession of the lateral rectus with a globe fixation to the medial orbital wall. This globe fixation, what I did was just like a DCR incision, put an incision there, expose the medial palpebral ligament and expose the periosteum, and then put a non-absorbable suture through the medial palpebral ligament at the periosteum, which was then brought out underneath the conjunctiva, and then the medial rectus area was exposed, and the suture brought out through the conjunctiva, sutured to the sclera at the level of medial rectus insertion. That is how you do it. It's a little time consuming, but it has got a very good result. This is the 2 weeks post-op picture. Supramaximal recess resect is a very good procedure. See, in this patient had a road traffic accident, presented with a large exotropia. The pupil recovered, and the patient had see this primary position exo, and on attempted levo version there was no movement of the medial rectus, -5 limitation of adduction. So in that case, ideal thing may be a lateral rectus transposition to the medial rectus, which is a very difficult procedure and is met with complications. So I just went and did the supramaximal recess resect procedure. See, supramaximal recess resect of both eyes has improved the condition, but there is still there is a residual exo. And on abduction or levo version, the adduction, the eye has come to the midline, not much adduction. And the patient was happy with this much of improvement, and I didn't do anything further. If you want, there is a risk of exotropic drift again. If the exotropic drift occurs, we can do a globe fixation. See, medial, in such a condition, the other alternative is to do transplantation of lateral rectus to the medial rectus. And that is a very difficult procedure, but this is a Patient, the report by Dr. Rohit Saxena et al. Published in British Journal of Ophthalmology, patient presented with a primary position large exodeviation with the absence of abduction, and they did a muscle splitting of the lateral rectus and transplantation of the lateral rectus to the medial rectus. You have to you have to split the lateral rectus as back as possible, and the upper part of the lateral rectus has to be brought underneath the superior rectus, superior oblique, towards the medial rectus, and the lower half has to be brought underneath the inferior oblique, inferior rectus to the lower border of the medial rectus, and it is their result. According to them, it gives a very good result. The eye will be immobile, but in primary position it will be straight, and the binocular field of no diplopia will be brought to the center. So this is an effective surgery, but is met with complications like a choroidal hemorrhage, and the surgery is very difficult. Yeah, in such a case, supramaximal recess resect is enough. And when there is an aberrant regeneration, things are different. See, this patient has got a ptosis, the eye is fixed in abduction, and when the patient is adducting, the eye goes, the lid goes upwards. So this is due to aberrant regeneration. The fibers which are destined to go to the levator muscle is supplying the medial rectus. So this is aberrant regeneration. This can be tackled by resection of the medial rectus, recession of the lateral rectus, and then a superior rectus recession of the opposite eye to tackle the aberrant regeneration. See this postoperative result, good result. So when there is an aberrant regeneration, you tackle accordingly. And what about ptosis in third nerve palsy? Frontalic sling, it can be done, but remember that if there is no Bell's phenomenon, there is chance of corneal exposure. If there is a superior rectus is partly recovered, you can do opposite superior rectus weakening. Levator resection can be done in partially recovered cases. And in aberrant regeneration, I have already discussed. Crutch glasses can be given in such conditions. Thank you very much for the patient hearing.